we discussed how you assess symptoms to reach a meaningful conclusion as to what the child has presented with, what is the physiology of that. This is a logical beginning to examining the child. And when we examine the child also, there is a certain scientific sequence that we follow which should lead you to the correct diagnosis in the end. So when you see the child, the first question in the exam hall or otherwise that we need to ask is this child comfortable or in distress? It is always worth emphasizing that whenever you are examining a child, that child could be potentially critically ill. Therefore, it is important for you to recognize that, and your examination of the baby's color, look, activity, the pulses, the respiratory effort, these are the things that answer the question, is the child comfortable or in distress? Having ascertained that your child will give you time to examine, you start about in a methodical way a pediatrician would approach a child. That begins with appropriate anthropometry. You need to know the height and weight of the child and where appropriate in a smaller child the head circumference. Please see whether there is any cyanosis or clubbing. You would note whether there is any failure to thrive from the anthropometry data. And you will make a head-to-toe examination for congenital anomalies. For instance, there is an abnormal facies that is staring at you, or a limb anomaly, or a polydactyly, or syndactyly. Apart from noting that these things exist, there are also certain pointers to predicting what type of heart disease could be associated with the type of anomaly that you have detected. For instance, if you have noticed that it is a Down syndrome, in your mind you are looking for evidence of AV canal defect. Similarly, if you have recognized that it is Williams syndrome, in your mind you are looking for evidence of supravalvular aortic stenosis. Therefore, there is a correlation between what you make out in the general examination and being prepared for certain findings as you go along. And obviously, if it didn't strike you, then you're going to miss the second part also. Look at these phases. You are familiar with this. The first one is the Williams syndrome, where the cocktail phase passive look, where the child is very friendly, has a triangular face, that broad philtrum. These things point to Williams syndrome, or in DiGeorge syndrome, again the triangular face, small puckered mouth, somewhat broader upper lip, the pointed nose. These are the things that tell you that you are dealing with DiGeorge syndrome. Or in Noonan syndrome, the whitely spaced nipples, the webbing of the neck, or the telltale look of Down syndrome. These are only some of the common syndromes that you should be familiar with. And mind you, in a large number of dysmorphisms that you might encounter, it may not fit into a specific syndrome that you are able to diagnose there. However, it is important to note that such dysmorphism exists. So having done these things, having ascertained that the child is comfortable, made a head-to-toe examination, found out whether the child has cyanosis, clubbing or something, taken a note of the abnormal facies if present, then you are going to examine the cardiovascular system of the child. When you do examine the cardiovascular system of the child, you begin with the pulse. The pulse is a pressure distension wave due to the ejection of blood into an already filled aorta, propagated along the arterial walls and palpable in all superficial peripheral arteries. Look at the components of the definition. What you feel is a pressure distension wave. Why does it occur? It is due to the ejection of blood into an already filled aorta. How does it reach you? It is propagated along the arterial walls. Where do you feel it? In any superficial peripheral artery. Conventionally, you examine the right radial pulse for the details of the pulse and the other pulses for their presence, absence, and also for specific features. The pulse wave, as you would know, has some components. The ascending limb of the pulse wave has a percussion wave and a tidal wave. Normally, the two are superimposed and you recognize only one upstroke. But the percussion wave is the impulse generated by the LV ejection into the aorta. And the tidal wave, these are reflectance waves, which as the blood or the initial pulse wave is reaching the periphery, there is a recoil from there. These are the reflectance waves. They get superimposed on the distal part of the percussion wave. So they are mainly from the upper part of the body. And the dicrotic wave is the recoil of blood from the closed aortic valve and also the reflectance wave from the lower part of the body. If you look at this pulse wave, note that this has not been split into percussion wave and tidal wave. It is a systolic peak. It is followed by a dicrotic notch, and here it has touched the baseline, that is the diastolic pressure, from where you are going to start again. So when you do see the pulse, there is a way of describing it. You say that it is so many beats per minute. So the rate, rhythm, volume, character, radiofemoral delay, and peripheral pulses, present, absent, their volume. The rate you say as so many beats per minute, and that is to give you a clue. Is it normal? Is it tachycardia? Or is it bradycardia? In pediatric practice, in relation to age, you need to say that whether it is normal or not. For instance, the pulse rate of 140 in a newborn is normal, whereas the pulse rate of 140 in an older child would be sinus tachycardia or an abnormal rhythm. The rhythm, having noticed the rate, you look at the rhythm to see whether it is regular or irregular. We will come to that. The abnormalities of rhythm, the rhythm is the regularity with which one beat follows the other. So if there is a certain method in the irregularity, as we speak of method in madness, it's like bigeminy or trigeminy. You say that pulse is occurring in groups of 2 or groups of 3. Groups of 2, you call it bigeminy. Groups of 3, you call it trigeminy. To illustrate with bigeminy, there are certain specific rhythms or arrhythmias which are responsible for bigeminy. The commonest among the rhythms that lead to bigeminy is an alternate ectopic beat, either ventricular or supraventricular. But if there is a Wenckebach phenomenon, if it's a 3:2 Wenckebach, mind you, the ventricular beats will be grouped in 2 and you will get a bigeminy. It can also happen in atrial fluster, which will always have an AV block. If the AV block is a 4:1 block alternating with 2:1, so that the ventricular responses are grouped. So these are the common rhythms that lead to a bigeminal rhythm. It could be absolutely irregular, as would be the case in atrial fibrillation or with frequent ectopic. Just remember, atrial fibrillation is extremely uncommon in pediatric practice. When it occurs, it is likely to occur in postoperative congenital heart disease where there has been an atrial surgery and it has been standing for a long time, of duration of a long time. This is very unlikely to occur in the first 12 years of life. So atrial fibrillation, if you diagnose in pediatric practice, think several times. After checking the rate and the rhythm, you are looking at the volume of the pulse. The volume of the pulse is the amplitude of the expansile movement of the vessel wall. And you normally feel the pulse with your 3 fingers. So it is the middle finger that you use to assess the volume of the pulse. To know the amplitude of the expansile movement of the vessel wall. It can be normal, low or high. And a quantitation of the volume is given by the pulse pressure. A low volume pulse will be associated with any low cardiac output state, or typically illustrated by severe aortic stenosis or severe pulmonary artery hypertension. A high volume pulse could be physiological, as in pregnancy, when you have had a bath in a warm water, or fever, or it could be related to conditions like aortic regurgitation or ductus arteriosus or an arteriovenous fistula. Apart from these, apart from being low, high, or so, the volume of the pulse may show some characteristic variation. Two particular forms merit description. For instance, the pulsus alternans means that alternating pulse beats have a lower volume. It is a marker of severe left ventricular failure. What is happening is that in the lower volume pulse, the electromechanical coupling in response to the electrical stimulation does not capture the whole of the myocardium. As the whole of the myocardium is not involved in contraction, the consequent pulse is small in volume. But when the consequent pulse is small in volume, there is a certain amount of blood volume that is added on due to stasis to the next beat. So in the next diastole, there is not only the normal filling that is coming in, but this carried on volume. As a result, it elicits a greater stretch, and which involves the whole myocardium, and now you get a higher volume pulse. This alternates, and you call it pulsus alternans. This cycle may be triggered by an ectopic region, and you recognize pulsus alternans most easily if you have an arterial line and the pressure waveform is on display. You can recognize it by palpation less commonly, or it may strike you when you are recording the blood pressure. The cortical sounds are noted as of having alternating intensity. Now, the other important abnormality in the volume of the pulse is the pulsus paradoxus. It is an exaggerated inspiratory decline of the pulse. Why exaggerated? Normally, when you take an inspiration, there is a holdup of blood in the lung and a decreased return to the left heart. So as a result, in inspiration, as such, the left heart output is slightly less than in expiration. So that if you have an arterial line pressure on display, you note that the inspiratory pressure is a few millimeters lower than the expiratory systolic pressure. Up to 10 millimeters, we would accept as physiological. If it is more than 10 millimeters, you use the expression pulsus paradoxus. It is best elicited by sphygmomanometry. You imagine that you are just checking the blood pressure as routine. As you are checking the blood pressure, how do you do it? You elevate the pressure to a level, the cuff pressure, to a level that will obliterate the palpable radial pulse. As you are bringing down the systolic pressure, the pressure in the cuff, you first hear cortical sounds somewhat spaced, and you realize that you are hearing the sounds in expiration. In inspiration, sounds are not heard. As you lower the cuff pressure further, you are able to hear it in both inspiration and expiration, and hence continuously you are hearing it. So this is the best way to elicit a pulsus paradoxus. It is seen in cardiac tamponade, constrictive pericarditis, or in non-cardiac causes like status asthmaticus, particularly in adults. Now we move to the character of the pulse. The character of the pulse are certain distinctive features of the pulse, which, as we describe, will become evident to you. For instance, you have the collapsing pulse of aortic regurgitation, which is a high volume pulse with a rapid upstroke, ill-sustained peak, and a rapid downstroke. It is appreciated with a distal palm, and you should elevate the patient's arm to appreciate this. You are elevating it so that the subclavian comes in direct line with the aortic arms. So it's a high volume pulse with a rapid upstroke, ill-sustained peak, and a rapid downstroke. There is a way to elicit it. Like the high volume pulse, it can be physiological in hyperkinetic states, in fever, anemia, thyrotoxicosis, pregnancy, or it means an aortic runoff as in aortic regurgitation, ductus, ruptured sinus, arteriovenous fistula, truncus, VT shunt, macta, anything that causes a runoff from the aorta. So that was collapsing pulse. The Bispherians pulse is a double beating pulse. Whenever you feel the pulse, you feel that the pulse is hitting your palpating finger in two. So the Bispherians pulse is a double beating pulse. This happens because both the percussion wave and the tidal wave are palpable. And the commonest cause is chronic severe aortic regurgitation. Aortic regurgitation accompanied by mild moderate aortic stenosis, also you may feel it. In hypertrophic cardiomyopathy also you may feel it. If you see these pulses, if this is the normal arterial pulse in which the percussion wave and the tidal wave has not been split with the dicrotic wave here, this is the pulsus alternans. See that this systolic pressure is higher and this is lower. This is higher and this is lower. Mind you, pulsus alternans is an abnormality in the volume of the pulse, not in the character of the pulse. While pulsus Bispherians, now you see, unlike the normal pulse, here the ascending limb is split into the percussion wave and the tidal wave. So it is the prominence of the tidal wave and a little delayed occurrence of that, or marking of this note, which makes the Bispherian pulse to be palpable. This of course is followed by the dicrotic wave, which is never palpable, and then such as diastole. So here you have the pulsus Bispherians with two peaks as you are palpating it. Here again you have pulsus paradoxus. Mind you, it is an abnormality in volume and not of character, where in these are the lower volume pulses which is seen in inspiration and the higher volume pulses of expiration. When you look at other causes for abnormal pulses, the dicrotic pulse is again a one in which you feel two peaks in the as you are feeling the pulse, and this is because the dicrotic wave is palpable. Normally, the dicrotic wave is at an insignificant impact on the palpating finger that you never recognize it. But the reason for that is the normal vascular tone. If that vascular tone is lost, as in toxic fevers, then you are able to feel the dicrotic wave. So in the past, we used to say that this is characteristic of typhoid fever. Today, there are far more toxic fevers available like dengue, and you are likely to feel it done. Yet another abnormal pulse is the pulsus parvus, et tardus. Too much of Latin in that, but that only means it is low volume, which is parvus, and slow rising, which is tardus. This is a feature of severe aortic stenosis. The anacrotic pulse is a notch on the ascending limb of the pulse wave, which is seen in severe aortic stenosis. This is more often seen in the ascending aortic pressure trace. If you are attending a balloon aortic valvotomy, in severe aortic stenosis, before you have done the balloon valvotomy, if you see the ascending aortic trace, you will invariably note the anacrotic pulse. Occasionally, this can be felt in the carotid pulse. In the radial pulse, you do not feel it. So from the character, we move to the next one, which is the peripheral pulses and the radiofemoral delay. You have to simultaneously palpate radial and femoral pulses, and you find that the femorals are absent, feeble, or delayed. It commonly denotes coarctation of aorta, but aortoarthritis and other causes of arterial occlusion should be considered in context. If you are dealing with an older patient, for instance, atherosclerotic aortic valve disease, so atherosclerotic occlusion of the aorta does come in the picture. Having dealt with pulse, now we are going to blood pressure. Shall I stop for a moment and ask you if you have any questions on pulse? I'll give you a few seconds to ask a question, otherwise I'll move on to the next topic and you can ask me later. Okay, we move on to blood pressure. You know what the blood pressure is. It is a lateral pressure exerted on the arterial walls by the passing blood column. And for recording blood pressure in children, you use a sphygmomanometry with a pediatric cuff. Remember, in a neonate, you may not have an appropriate size cuff. And then there is the old flush method where you use a cuff to inflate the pressure to produce a blanching of the forearm. And as you are lowering pressure in the cuff, you see the pressure at which the forearm flushes, and that denotes the mean arterial pressure. It's an old technique of recording. Once in a while, in our country, it would still become useful. More often, you are all familiar with the so-called non-invasive blood pressure. Mind you, it's an oscillometric technique which is recording the blood pressure and which will give you both a systolic and a diastolic pressure with the mean recording. So these are the different ways of recording blood pressure in children. And when you do record by sphygmomanometry, remember what you're hearing are the Precordial sounds. The Precordial sounds occur in 5 phases. The phase 1 is the appearance of the first loud tapping sound. This is followed by somewhat softer sounds which are a little longer, so you may consider it a soft murmur. And in phase 3, it becomes still louder. And when it muffles, you say that you have reached the phase 4. And phase 5 is the disappearance of sounds. For blood pressure recording, generally phase 5 is taken, even though technically phase 4 may correspond better with intra-arterial blood pressure. This is because a phase 5 blood pressure reading is more easily reproducible and is likely to be the same with different observers. And what is hypertension? It is more than blood pressure more than 95th centile for age. I will not discuss that in further detail. So after pulse and blood pressure have been seen, you are moving to the jugular venous pulse. It is measured in the right internal jugular vein in older children and adults. Why would I say only older children? In neonates and infants, where the neck is rather short, it is not possible for you to inspect the venous column clearly. Therefore, you would look at the liver for evidence of right heart failure rather than the JVC. But in an older child who is able to cooperate, or in an adult, you can make him sit up or take the traditional 45-degree reclining position to look at the right internal jugular vein pulsations. And the normal waves, which I would illustrate shortly, you have the A wave, which is denoting the atrial contraction, the V wave denoting the ventricular contraction, the X descent, which shows the tricuspid valve descent with right ventricular systole, or the Y descent, which shows the right atrial emptying with tricuspid valve opening, and rarely the H wave, which shows the passive filling of the right atrium. Let's look at this picture. Here is the A wave. See the corresponding picture below as the atrium is contracting. So this is a pre-systolic wave. How do you say that it is pre-systolic? Put your finger on the opposite carotid and you realize that the wave that is coming is just before the carotid pulse. And once you have seen the atrial pulse, sorry, the A wave, the next thing to happen on the descending limb, on a trace you often find a carotid artifact, which is the C wave, and the further descent, which is the X wave. This is the X wave. That X wave is related to the descent of the tricuspid valve during ventricular systole. Then there is a passive filling of the atrium, which generates the V wave. But mind you, even though the V wave is a diastolic filling, when you see a V wave in JVP, that is because there is an active pumping into the right atrium due to tricuspid regurgitation. Therefore, you will find it in late systole, not in diastole. So, a V wave is again a systolic wave as far as the abnormal V wave is concerned. Then, After the V wave, you have the Y descent, which is the opening of the tricuspid valve and letting go of the right atrial blood, and you are going over to the next A wave. The transition between these may be marked by a hump, which is called H wave, which is prominent in constrictive pericarditis. So these are the normal waves in the jugular venous pulse. Now we must look at some causes for prominence of each of these waves. So prominent A waves, I already said, they occur just before the carotid. They are pre-systolic. The commonest circumstances in which you see them are either severe pulmonary arterial hypertension, particularly with an intact interventricular septum, as in a primary pulmonary hypertension, or severe pulmonary stenosis. You can also see it in tricuspid stenosis or tricuspid atresia. Tricuspid stenosis you will not see in pediatric practice, at least not commonly. And in tricuspid atresia, you will find a prominent A wave if only the interatrial communication is small. There are some peculiar A waves also. You say that they are Cannon waves when you find the A waves in systole due to an atrial contraction against a closed AV valve, like a volley from a cannon that comes abruptly, leads to your attention and disappears. So Cannon waves are systolic A waves, underlying systolic, due to atrial contraction against a closed AV valve, and this will occur with the carotid pulsation. So you could have a regular Cannon wave, which could occur with a junctional tachycardia if the abnormal focus is able to capture the atrium retrogradely. So a junctional tachycardia with retrograde atrial capture could produce regular Cannon waves, or it could be irregular, classically seen in complete heart block. It could also be seen in frequent ventricular ectopics. All that you require is that there be a situation in which atrial contraction occurs against a closed AV valve. Common situation, complete heart block and frequent ventricular ectopics. Now prominent V waves, they occur with carotid pulsations because something is pumping into the atrium. And what is it? It is tricuspid regurgitation. If there is an ASD with microregurgitation, it amounts to having a tricuspid regurgitation. Or it could be a Gerbode defect, like a left ventricle to right atrial shunt, again similar to tricuspid regurgitation. So then you get a prominent V waves. Then you have abnormalities like Kussmaul's sign, which is an inspiratory rise in the JVP, which is seen with constrictive pericarditis. So we have seen the pulse, blood pressure, JVP, and now we are looking at the precordium of the child. Please remember this sequence. And when you look at the precordium, the first thing that you would notice is the shape of the chest. Is there a pectus excavator, that's a depression on the chest, or a pectus carinator, it's a pigeon chest in which there is a forward protrusion of the chest, which denotes long-standing cardiomegaly in a young age, or it has not a problem with the sternum or the front of the chest, but with the spine, kyphosis or scoliosis. It's also appropriate to take note of any surgical scar. Say that there is a median sternotomy scar or a lateral thoracotomy scar or a posterior thoracotomy scar. It has some clues as to what is the possible surgery that the patient has undergone. For instance, if it's a lateral thoracotomy scar or a posterior thoracotomy scar, it's a closed heart surgery like a shunt or a coarctation repair, whereas a median sternotomy generally denotes an open heart surgery. Having noticed the shape of the chest and any scar, the first thing that you should feel and see is the apex beat. A question that most people will ask is, do you describe things in inspection and palpation? It's not necessary. You can combine them wherever possible so that you can give a meaningful description. For instance, the apex beat is something that you see and you palpate, so you can just describe it. And the apex beat is the lowermost and the outermost point of definite cardiac pulsation. Lowermost and outermost point of definite cardiac pulsation. If you don't feel the apex beat when the patient lying down, you can gently tilt into the left lateral position and note the character of the apex beat. As far as the location of the apex beat is concerned, the way it is located in the supine position is more relevant. So, having noted the apex beat, you try to describe its character. Let's say that it is normal. When it lifts the palpating finger, but not for any great duration. For a comparison, we say that it seems to lift the palpating finger for less than a third of systole. You call it tapping when there is a palpable shock or burst sound over the apex beat. You call it forceful when the palpating finger is lifted beyond the adjoining ribs. That is the magnitude of lift that you are defining. Normally, when it is lifted, it doesn't go beyond the level of the adjoining ribs. But with the patient turned to the slightly to the left lateral position, you can feel that the palpating finger is lifted beyond the adjoining rib and for more than a third of the duration of systole. So it is lifted more and it is sustained more, but not sustained for more than half the duration of systole. More than a third, less than half. If it is more than half, you would use the word heaving. In other words, the palpating finger stays lifted for most of the systole. The 1/3 half is for a convenient comparison. So the normal apex beat doesn't elevate it beyond the adjoining ribs and it's not sustained for more than a third of the duration of systole. The forceful apex beat, it is sustained for more than a third and it is elevated beyond the level of the adjoining ribs. And the heaving, it is all these for more than half the duration of systole. And the common causes for these, a forceful apex beat means an LV volume overload, a heaving apex beat means an LV pressure overload. You may also get certain characteristic features like a double apex beat in hypertrophic cardiomyopathy, where the apex beat is notched by the obstruction as it's coming to LVOT during the systole. It could be triple, where this double apex beat is accompanied by a fourth heart sound. So there we are done with the apex beat. Having felt the apex beat, now you are going to look at other pulsations. There are multiple areas where you can see the pulsations. Left parasternal pulsation, that's in the second, third and fourth phase, it suggests right ventricular volume overload, and these pulsations may extend up to the apex when the right ventricle forms the apex, as is the case with atrial septal defect. Pulsations in the left second phase denotes an enlarged pulmonary artery, and a left parasternal heave is the other thing. So first we spoke of pulsations at the left sternal border, including the second phase which denotes the pulmonary artery pulsation. Having noted that, you use your hand and see whether there is a left parasternal heave. It denotes an RV pressure overload, as would happen with pulmonary arterial hypertension, valve PS, particularly with intact interventricular septum. In pathology, you don't get a left parasternal heave because even though there is an RVOT obstruction, there is a large VSD which is decompressing the RV and preventing it from getting a progressive strain. After having noticed the left parasternal pulsations and the heave is present, you can gently place your fingers in the epigastrium and look for an epigastric pulsation due for RV enlargement. The whole of the precordium may pulsate in late systole, and that denotes left atrial pulsations in mitral regurgitation. What's happening is that the left ventricle is pumping into the left atrium being the most posterior structure that is pushing the whole of the heart forward, and that is responsible for the pulsations of the whole of the precordium in late systole to denote left atrial pulsations. And you may find pulsations across the sternum, sort of rippling pulsations, which are right atrial pulsations in Epstein's anomaly. And if you find sustained pulsations to the right of the sternum, it denotes ascending aorta. Mind you, we are referring to levocardia. If it's dextrocardia, it is a different implication. In levocardia, if you can feel pulsations to the right of the sternum, that denotes ascending aortic pulsation, classically seen with Marfan syndrome. Any questions? Same problem. There is an inherent problem in using the words right ventricular and left ventricular apex. I know that some examiners do ask for it. I would answer the question as to how do you differentiate between RV and an LV apex. A left ventricular apex is a localized apex beat. A localized apex beat, which is quite away from the left parasternal region, is left ventricular. So it will be either forceful or heaving, or it's at least normal. Mind you, the normal apex beat is formed by the left ventricle. In the case of a right ventricular apex, the right ventricular pulsations which are felt at the left parasternal region are continuous with the apex beat. So when there is a continuous pulsation from the left parasternal region to the apex beat, it is a right ventricular apex. What I would like you to do is to confine yourself to the description as normal, tapping, forceful, heaving, or any abnormal description, and the fact whether it is left ventricular or right ventricular, to keep it with you as a conclusion. Now the question of dominance, you have nothing to do with apex beat palpation. You speak of LV dominance or RV dominance based on multiple factors that you have got in your evaluation of the patient. So if you are looking at a cyanotic congenital heart disease, if you want to say LV dominance versus RV dominance, if you have a cyanosis and if you have an LV apex, it's a dominant LV. If you have a cyanosis and if you have a quiet precordium, you know that it is an RV dominance and that's a tetralogy of valve. But that is not related exclusively to the palpation of the apex beat. So in describing the apex beat, you are far safer in neutral territory when you describe the features of the apex beat. If somebody wants to you to answer whether it is LV or RV, see whether it is a localized apex beat or see whether it is continuous from the left parasternal region to the apex beat. So I'm proceeding on to auscultation now. Mind you, before reaching auscultation, we went through general examination, pulse, blood pressure, jugular venous pulse. We inspected the precordium, we located the apex beat, looked for any other pulsations, and then only we are coming to auscultation. In auscultation, again, one often asked the question, do you describe auscultatory findings over the mitral area, over the aortic area? I would say not. You describe the heart sounds, you describe the additional sounds, and you describe the murmurs. When you describe heart sounds, when you refer to the first sound, you need to say whether that S1 is normal. To say that S1 is normal, you need to auscultate in the apex beat and also in the tricuspid area. You don't conclude on intensity of S1 from the base of the heart, from the pulmonary area or from the tricuspid area. When you refer to the second sound, you have to comment on the split of the sound. Is it split? Is it single? And once you say that it is split, you need to say whether the A2 or the P2 is louder. If there is any S3 or S4, you need to describe that. And any other additional sounds also you need to describe. And any murmur you need to describe. So auscultatory findings are best described as heart sounds followed by murmurs, and when you get your finding, you of course say where it is best heard. So let us look at these heart sounds in some detail. How is the first sound produced? It is produced by the closure of the atrioventricular valve. It is appreciated as a single sound because the normal sound is produced by the mitral component and the tricuspid component. We call it the M1 and the T1. Normally, the M1 and the T1 are close together. It is estimated that the human ear does not perceive a difference between two sounds unless it is separated by at least 20 to 30 milliseconds. So, less than 20 milliseconds is the normal M1 T1 interval, and therefore the first sound is heard as a single sound. And the intensity of the first sound can be normal, it can be loud, it may be soft or muffled, or it can be varying in intensity. From beat to beat, there is a variation in the intensity of the first sound. We need to describe this. Before I go on to that, let's look at this picture in some detail. This is shows the relationship between the various things that you see. Here is the left ventricular pressure trace. Here, from the end diastole, the pressure is rising to a peak and then coming down. It will dip to a diastolic pressure of 0 and then slowly rise to an LV end diastolic pressure. That is the feature of the left ventricular pressure trace. Superimposed on the left ventricular pressure trace, occurring a small interval after the onset of the upstroke, is the aortic systolic wave, or the carotid pressure trace. Why is this interval? This is the isometric contraction phase, from the onset of systole to the opening of the aortic valve. So, following isometric contraction, you have the aortic pressure trace inscribed, which will be superimposed on the LV, and if it is carotid, it will be slightly delayed relative to the LV pressure trace. So that is LV and the aortic or carotid pressure trace. Now you have the jugular venous pressure here, or the atrial pressure, where you find the atrial contraction, which is this is the A wave, and this is where the fourth sound will come to that, and then this is followed by remember the A wave occurs before the carotid, then you will find a V wave which is late in systole, and you will find the X descent and the Y descent. This is illustrated in this, and also the occurrence of the S4 which is pre-systolic, the S1 which occurs just before the onset of the carotid, and the S2 which will occur during the carotid descent, and the S3 which will occur, you feel it over the apex beat or over the lower sternal border in diastole, or the S4 just before systole. We will be describing these sounds in some detail. Now let's come back to the first sound. We said the intensity of the first sound is an important thing that you look for. What decides the intensity of the first sound? You need a valve mechanism which is working well, which we describe as the integrity of the valve apparatus. Supposing the valve is densely fibrosed or calcified, the first sound is going to be soft, even if everything else is alright. That is what would occur in calcific mitral stenosis. Or the position of the valve leaflet. I use the comparison with a door closure. You look at your room's door, and you can close it in several ways, but in whichever way you close, the sound that is produced will depend on, first, is that door of a good quality, or is it creaky, is it going to fall down? If it is a degenerated creaky door, it is going to produce only a dull thud when you close it. But presuming that that door is of solid wood, then before you close the door, you open the door. Did you leave it with a widely open and then slam it shut? If you slam it shut from a wide open position, naturally there will be a loud door. That is why courtesy demands that you close gently. So that is the position of the door influencing the closure sound. Same thing for the valve. If the mitral valve was wide open before it started closing, you get a loud first sound. Supposing the valve was nearly closed before you started closing it, you get a dull sound. And there are examples for both. In the case of a wide open valve, think of a long PR interval. The atrial contraction has occurred and there is a long interval after which the AV valve is closing. You get a soft first sound. On the other hand, you have a short PR interval. Then just before the valve was about to close, it had been pushed open. So it has to close across a much longer distance and you get a loud S1. This is relating to two aspects of the door, the structural integrity of the door and the position from which the door started closing. Now, the way you close the door also matters. Wherever the door is, you can slam it shut. Wherever the door is, you can close it slowly also. This is what the left ventricle does. Your hand is the rate of rise of pressure in the left ventricle. The way you close the door with your hand can be compared to the rate of rise of pressure within the left ventricle. If the left ventricle is briskly raising its pressure in systole, we say in physiology that this is the dP by dt. If the dP by dt is increased, then you get a loud first sound. But if the left ventricle is able to close it only very slowly, generate the pressure only very slowly, example myocarditis, dilated cardiomyopathy, acute myocardial infarction, everything else remaining normal, first sound is still soft because the valve is being closed with a low rise in dP/dt. PR interval influences the position of the valve leaflets, and I have already explained that. So the comparison to the closing door gives you the mechanisms which will influence the sound of the first, the intensity of the first sound. Integrity of the valve apparatus, position of the valve leaflets, the rate of increase in pressure, and the PR interval. So for a loud first sound, you have mitral stenosis. Why in mitral stenosis? Because the LA pressure is high and the valve leaflets are apart when they start closing. Tachycardia, somewhat similar. Tachycardia in effect means like a short PR interval. So as the diastolic filling time is decreased, it has to be suddenly closed. Short PR interval, I've already explained. Conditions like VSD, PDA, because there is an increased flow across the mitral valve, which will keep the valve open till late in diastole, and also it will stretch the left ventricle and elicit a better dP by dt. So those are the reasons why a first sound is loud. And then at the opposite end of the spectrum, if you are looking at a feeble first sound, this can happen in acute mitral regurgitation, aortic regurgitation. In acute mitral regurgitation and aortic regurgitation, the S1 is feeble because there is an acute increase in the LV end diastolic pressure, and the high LV end diastolic pressure is already closing the mitral valve. So with the onset of systole, the actual range of movement is very little, hence the feeble first sound. In viral myocarditis, dilated cardiomyopathy and acute MI, it is because the rate of rise of pressure is low. So this is either loud or feeble, but it needs to be neither. It can alternate between loud and feeble to normal. This classically happens in complete heart block. This is because the relationship of the atrial contraction to the ventricular contraction in complete heart block is variable. You get an apparent PR interval which is short or an apparent PR interval which is long. Accordingly, that decides whether where the valve leaflets will be when it's beginning, LV is beginning to contract. Same thing in ventricular tachycardia because there is an AV dissociation and the atrial and ventricular contractions are unrelated, or in frequent ventricular ectopic or in atrial fibrillation. So a varying intensity is the feature in these conditions. We also said that the first sound could be split. We explained why you don't normally hear the split, because the M1 T1 interval is rather narrow, and if it's more than 20 milliseconds, you are able to appreciate it. This could be done in complete right bundle branch block or extreme anomaly. I will not go to the second heart zone today. I'll stop here and respond to any questions from you. I would like to answer this question when we are discussing H2. So there is a purpose in stopping at this point. It is to force you to think on things that we have discussed, not on things that we are yet to discuss. So ask me this question next day. No questions? In this case, okay. Okay, you wanted to know whether you can explain the LVDPDT. You look at this part of the, actually the picture does not show the diastole in detail. When the LV pressure rises, look at this part. This is a fairly steep rise in pressure. This can be much more slower like this. I hope you are seeing my arrow. This can be much more slower, which means the LV is generating the pressure much more slowly. The dP by dt is a physical mechanism to analyze how slow this is happening, and there is a measure to that. Without answering how exactly it is measured or what is the normal, let's say that a high dP by dt means it is rising abruptly like this, and a slow dP by dt means it's rising slowly like this. So when the dP dt is slow, the peak pressure achieved is usually slow. More importantly, the peak pressure is achieved over a greater period of time. So the dP is the pressure and the dt is the time required for that. So you are analyzing the relationship of that. Any more questions? Then thank you. I'll see you again on Tuesday. We want to leave the meeting now. Yes. Any meeting for you? No, we don't need to.